flip radiology on its head, typically an imaging center pays a radiologist a flat fee to read the study and then bills globally, bills for both the interpretation and the scan. Flipped that on its head, I paid a flat fee to the imaging center for the scan. We interpreted the exam and we billed globally.
Paging Dr. Cook. Paging Dr. Cook. Dr. Cook, you're wanted in the OR. Dr. Cook, you're wanted in the OR.
Welcome to the Prescription for Success podcast with your host, Dr. Randy Cook.
Hello, everyone, and welcome to Prescription for Success. I'm Dr. Randy Cook, your host for the podcast, which is a production of MD Coaches, providing leadership and executive coaching for physicians by physicians to overcome burnout, transition your career, develop as a leader, or whatever your goal might be. Visit MD Coaches on the web at mymdcoaches.com because you're not in this alone. My guest today founded Green Imaging for the purpose of providing affordable, high-quality imaging services for the uninsured and high-deductible patients in Houston, Texas. Her effort has been wildly successful and currently is available in most U.S. states. To get the details, let's hear Dr. Cristin Dickerson tell her story. I'm really excited today to be speaking with Dr. Cristin Dickerson out in the Houston, Texas area, who has a fascinating story to tell. And it particularly fascinates me because it's coming from a radiologist who has a really intense interest in how we're going to deal with the ridiculously out of control prices of healthcare. So, Cristin, thank you so much for being with us today. I'm looking forward to the conversation.
As am I. Thanks for having me, Randy.
Well, I think this is going to be fun. As usual, I like to begin with the beginnings, and that means I'd like to know when you began to develop an interest in a medical career. Was that like an early childhood thing, or did it come later?
It really wasn't. I got a good paying job in high school as an EKG technician. And I was only 16, but a friend of my parents was running the department and needed an evening tech. And it was better pay than I could get doing anything else at that age. And so I became an EKG technician. And that was really the start of looking at medicine as a possible career. There were so many, medical mysteries that the fun part of medicine for me is, and that's why I'm a diagnostic radiologist, is solving what's wrong and pulling all the clues together and coming up with what in this field is a diagnosis.
Mm-hmm. So you didn't really have any medical influencers in your family. This was something that you discovered quite by serendipity, it sounds like.
It really was. No, I'm from a family full of lawyers, actually.
Oh, my goodness. And then an interesting thing happened. You had a good academic background, but after your graduation from Baylor, you took a year off to do a research project as a research assistant in nuclear medicine. How'd that come about?
I did. Because I screwed up. I was a kid and I missed a deadline on an application for the medical school that I really wanted to go to. I had them all stacked in one of those crazy things. Mm-hmm. And so it really ended up being a great year, and also convinced that I was intent on being a doctor at that point, having worked that year in actually nuclear medicine, so a related field. Sure. I've had enough experience there that I knew that's what I wanted to do.
Can you think of anything that you learned during that year that really served you later on in your career?
I can. I loved the relationships, both of the physicians and the staffs of different practices working together and exchanging patients and information. And in this practice, there was a lot of thyroid disease. And so these patients came back year after year for their scans and their uptakes. And those relationships were fascinating. And so I think I moved from the science end of healthcare to the people end of healthcare.
Yeah. As a research assistant, and what was the nature of the research that you were involved in?
It was nuclear medicine, basically the outcomes of thyroid ablations, and for both cancer and for hyperthyroidism. The doctor I was working for, Herbert Allen, was really a pioneer in nuclear medicine.
So it wasn't, it was actually interventional medicine. It was not just imaging.
Correct.
Yeah, I bet that was really fascinating. But then you finally got your ducks in a row in 1985. You're in medical school at University of Texas in Houston. And what was it like in that first year, did you think? Yeah, I really hit it out of the park, or did you ever have any second thoughts, or what was going on?
No, I really didn't. And I loved, when it really got fun was the third year when we started doing the clinical rotations. That was the great part. The first 2 years, I think I had a really good basic science background that helped me, get through those first 2 years pretty easily. The clinical part of it got really fun. And then once we got into the electives in the fourth year, that's when I discovered first elective I did was radiology. And I knew that's what I wanted to do.
And did you have a premonition of that, or did the radiology elective just happen accidentally? Or
it happened accidentally, and it was an alternative. I had always found the diagnostic piece of medicine to be the fascinating part, or the most interesting part. And the other piece of that, later I did pathology, which is a very similar thought process.
Really? Yeah,
and I
really
did it as an elective. Yeah, and it's very similar. And I probably, if I had done it first, I might have considered, although I always see my eyelashes in the microscope, so that may not have been okay. But
I guess that could have been a hazard.
Yeah, it might have been a hindrance, but
you would have probably found a way around it.
I probably would have figured out how to do it right. But anyway, I loved the thought process. And as far as the other specialties, I thought nephrology was fascinating, hepatology, rheumatology. Those were other diagnostic dilemmas that I really enjoyed.
But that's pretty good that you were able to figure that out early along the way. And I'm assuming that you probably took more than the average number of radiology electives during your last couple of years, as I guess most radiology residents are sort of required to do. You did an internship year, I guess, in general medicine and those sorts of things.
Yes, I did a transitional year, which is you're able to rotate through, which I think is awesome for a radiologist because you get the clinical background, and we're really kind of a doctor's doctor. And so you get the more of a clinical background in multiple specialties and subspecialties. And so that was a really great year. It goes back and forth about whether internship, it's state by state, and also just the recommendation for whether or not radiologists should have a clinical year. It tends to go in and out of fashion. The latest fashion has been, it's been more important to have a fellowship, but then we lose the guys who can just, cover everything and make sure that a practice, has emergency coverage. So I am a general radiologist, although I do have, things that I have trained longer and harder in and have much more experience in, especially oncology. And that was one of the blessings of training in Houston, was that I trained at MD Anderson and, got a very strong background in cancer imaging.
Well, I know that as a surgeon, I'm prejudiced, but I have to tell you that my feeling is that radiologists who have some experience, some substantial experience at bedside care, are better at what they do. And I'm wondering if you think that I'm right or wrong, or it could go either way with that.
I absolutely agree with you. And I think that's how I ended up I spent most of my career with multi-specialty groups, with the two large prestigious multi-specialty groups here in Houston, Diagnostic Clinic of Houston, straight out of residency, and then Medical Clinic of Houston, adjacent to the Texas Medical Center.
And when you got into your residency training, did you have the feeling that, wow, this is about as good as it gets, I'm really right where I want to be, or were there ever any doubts at all?
First day was at MD Anderson in this big reading room. We still were on film, and they had light boxes surrounding this huge room.
Mm-hmm.
And by the end of the day, it's amazing how much you have to build your eye muscles to practice radiology.
Yeah.
By the end of the day, the first month, I was just exhausted, but I loved it. And we had, probably one of the, top 3 faculties in the country at that point in time. So it was very exciting, and it was a great start.
I'm really not sure at looking at your CV if you had some particular leanings and special areas where you would like to concentrate. Did that occur to you at all at that point?
At that point in time, MRI was brand new. People weren't being trained, in subspecialties as much as being trained kind of on the new modalities. Mm-hmm. And so I became a junior faculty my last year and helped staff the MRI facility. So that was basically a mini fellowship. Mm-hmm. But like I said, I think my passion has been cancer imaging of all types, including breast imaging. And the other thing that was emerging when I finished residency, I actually participated in the first stereotactic breast biopsy at MD Anderson and at LBJ Hospital here, which was the county hospital. I was the chief resident, and so I got that privilege. And when I went to diagnostic clinic, they had just purchased a stereotactic breast biopsy machine. So, of course, that went to the new radiologist. And I had a thoracic surgeon tell me it's never going to become the gold standard. It's always going to be surgery. And pretty soon he became my best referral source.
Yeah, well, it's funny. I remember those days as well. In fact, I was just thinking about the early days of MR, and my experience was to see it in 2 different perspectives. I worked at a really busy multi-specialty group in the Tampa Bay area, and we got into on-site MR right away, and then I decided to move back home to Alabama. And when I did, the MR was something that came up and visited on a truck every now and then.
Right.
So, there were so many unanswered questions at that time. And I think it's reasonable why people would look at that and say, if you got to go through all this, how is it ever going to become a thing? But it certainly did. Let's move you on to what happened next. It looks like your first private practice experience was with Diagnostic Clinic of Houston. It's my understanding that the philosophy of this group, it sounds like, was pretty much like what the name implies, and that is it's all about evaluating and getting to a diagnosis and then referring to specialty as necessary, as opposed to having specialists on the site. Was that about the size of it?
We did have a number of specialists, but they were medical subspecialists. We didn't have surgical subspecialists. We had many surgical subspecialists who were right down the hall and worked with us very closely. But, having been president of that group and figuring out how to pay people, it was always kind of a challenge to incorporate the surgeons and the medical people in the same practice. Even that practice very successfully had radiologists as partners. And the philosophy there was, and I think it was a great one, was that the radiologist would make the best decision about new equipment, about the expense of new equipment and the risk of new equipment, right, if they were invested. And it was absolutely true. And, that we very much were part of the financial equation and figuring out if new equipment was justified or not. And I loved that part of it. And I loved working that closely with these doctors. We actually sat down to lunch every day together and would discuss patients. And I think that's actually
what a great idea.
Yeah. And isn't it funny that that's gone away?
It's just heartbreaking for me.
It is heartbreaking. No, that some of the best ahas happened in that setting. And plus we had the camaraderie. We knew each other. We knew about each other's families. It was more, you talk about a great culture. That clinic had a wonderful culture.
And so this evolution into the radiology group of Houston, was that actually associated with Diagnostic Clinic, or was it a totally separate entity?
Along the way, we digitized. There are a couple of stories that happen here. Number one is that I really went to Diagnostic Clinic of Houston because I never wanted to be involved in the business of medicine, quote unquote.
Oh, really?
That was my
How'd that
justification.
work out for you?
And what happened was we had a new business office manager who brought me in this huge box of what we called yellow tickets. And they were the tickets that the hospital would give us for the work that we did nights and weekends on call. And she showed me that most of them did not have enough demographic information to collect from the patient. And so that was my nights and weekends away from my kids and family that we were basically giving away. And so I thought I might get involved at that point. And I ended up 2 years later becoming president of the multi-specialty group. In 2005, we were on a mission to become, one of the early digitized radiology departments and in the freestanding world. And so within about a year and a half, we were able to accomplish that. And at that point in time, we had 6 radiologists, but our workload became that for 3 radiologists. And instead of letting go of partners, I decided I would go out and get us some additional contracts. There were plenty of imaging centers who could use our help. And so founded Radiology Group of Houston on the side.
At what point and how did that evolve into green imaging?
We were practicing with multiple, the Diagnostics Clinic of Houston was ultimately acquired, and they had to let the radiology department go because it was competing with the hospital that somehow got financially involved with the group. And so it was blurry to me because I wasn't at that point involved. So it was really easy for us. We already had this radiology group and just continued, to practice outside of that. So that was really seamless. But in 2010, 2011, it started becoming clear to me that in Houston, friends would call and say, hey, they want $3,000 for this MRI over at the hospital. Where can I go get an affordable exam? And there weren't good options. In fact, the large chain of imaging centers had been acquired by a hospital, and then that was the in-network option. And so the other problem was that, the ones that did have self-pay rates, the self-pay rates were all geared toward the Texas Medical Center international visitors. They were sky high. And so there wasn't a good option. And so I decided to solve that problem. Got a pro forma to build an imaging center, similar to the one we had done at Diagnostic, and it was going to be $3 to $4 million. And I knew I couldn't offer good pricing. My prices were going to have to be the same as everybody else's. So at that time, a lot of the sharing models, the reselling models, Travelocity, Amazon, things like that were emerging. And the Stark laws allow radiologists more latitude than other physicians for lease arrangements. And so since we were reading for multiple imaging centers in Houston that were at half capacity, I got the idea to try to buy the extra time on their scanners at a discount. Flip radiology on its head. Typically, an imaging center pays a radiologist a flat fee to read the study and then bills globally, bills for both the interpretation and the scan. Flipped that on its head, I paid a flat fee to the imaging center for the scan. We interpreted the exam and we billed globally. And so we built pretty quickly. I would say within a couple of years, we built a great Houston and then Texas network of imaging centers using that model. So that was really the start of green imaging.
Hi, I'm Rhonda Crow, founder and CEO for MD Coaches. Here on RX for Success, we interview a lot of great medical professionals on how they grew their careers, how they overcame challenges, and how they handle day-to-day work. I really hope you're getting a lot of great information. But if you're looking for an answer to a specific problem, management or administration challenge, or if you're feeling just a bit burnt out, like maybe you chose the wrong career, well, then there's a faster way to get the help you need. No, it's not counseling, it's coaching. RX for Success is produced by MD Coaches, a team of physicians who have been where you are. I know you're used to going it alone, but you don't have to. Get the support you need today. Visit us at mymdcoaches.com to schedule your complimentary consultation. Again, that's mymdcoaches.com. because you're not in this alone.
We'll get back to our interview in just a moment, but right now I want to tell you a little bit about Physician Outlook. If you haven't discovered this remarkable magazine, please do so very soon. It was created by physicians for physicians to showcase the intersection between clinical and non-clinical interests, whether it's writing, painting, cooking, politics, and dozens of other topics. Physician Outlook gives a physician perspective. It's available online and in print. It's really unique among physician lifestyle magazines. And like the Prescription for Success podcast, Physician Outlook amplifies the voice of any physician who has something to say. It also engages patients who still believe in physician-led, team-based care. And Prescription for Success listeners can get 3 months free when you enter our promo code RX for Success and select the monthly option at checkout. That's a really great deal on this stunning publication. And now let's get back to today's interview. Green imaging has quite a large reach nowadays, right?
We do. Solving the issue of multi-state coverage was one that took me a while to really wrap my head and hands around. And the problem is that it's one thing to market to individual patients, to self-pay patients. Where you really can have the most impact is health plans. And about 50% of the health plans in this country, 50% of people are covered by a health plan. Actually, it's their employer that is sponsoring that healthcare plan. And so self-funded healthcare plans are where the volume is. And so if I was really going to grow this nationally and help the most people possible, I needed a way to be in all states, because if you have somebody in a health plan, they may be located in Kissimmee, Florida, but they may have kids, living with the mom in Montana. And so you really have to have a much wider reach than just one state. I couldn't be HEB and just be in Texas. I had to, to have a national footprint.
Mm-hmm.
And, aside from, I don't want to have 50 medical licenses to do that. That was not attractive. That CME would be, I think it would take all of my time. And so, but we had to figure out a model to work around that. So what we do now is, where we have a large number of covered lives, as we do in Texas, Florida, Georgia, Colorado, Louisiana, we get our licenses and we read those studies. Where we don't have a large number of covered lives, we serve more as a traditional imaging network, with the difference being that we have as radiologists, we have peer review access to images and reports. So if there's ever a question of quality, we can jump in there and take a look at that, and assure that the proper exam was performed and that the report is accurate and quality of the exam. And so it really creates a huge differentiator for us as compared to any other imaging networks.
You've got a lot of centers out there. I'm embarrassed to say, of course, I've been retired for a couple of years, but I was not aware of the existence of green imaging, and a quick Google search showed me today that there is a center less than 20 miles from where I live, and I live deep in the wilderness of East Alabama.
The central and southern East Coast, the South, and all the way across to California, we're just starting to get a significant number of covered lives. But as far as Arizona, then up to Utah now, that's our best geographic area. And now, those are obviously the most populous as well.
And along those lines, I was going to ask you if you find some states measurably more difficult than others. Is it a huge stumbling block, or are most all the same?
A huge market variability. Yeah. Boston, 90% of the imaging is performed in the Mass General system or at Boston Children's, and there's very little outpatient independent imaging performed there. And, so what is there, they do typically replicate the Mass General protocols, which are long. And so it's more time on this machine, and the exams cost more. I would also say that Texas and Florida are very competitive markets in the direct contracting world. While they are hospital dominant, maybe the hospital domination has led to physicians breaking off and or staying independent. But what we're hearing in the self-funded healthcare plans is that Texas and Florida are great markets for that. For whatever reason, we've been pushing the Free Market Medical Association here in Texas and really trying to get the word out to doctors that they have this option to not be beholden to the insurance companies and hospital systems.
Really sounds like a great idea to me. And then the question that I suspect a lot of our audience is asking is what makes green imaging green?
There are a couple of things that make green imaging green. Number one is the money that we save. We're able to save.
You can't get greener than that.
You can't get greener than that. We save individuals and health plans about 60% as compared to the typical price in a hospital system or in a self-funded healthcare plan. And some exams we're 20% of the cost of the same exam in a hospital. And then the other is the fact that we do not open new brick and mortar. Instead, we use existing resources and, use the untapped time on the table. And the interesting thing that happened to us early on is, usually radiologist sits or at least at that point in time, now it's mostly teleradiology, but at that point in time, they sat in a dark office and, just read what was handed to them. We started bringing, patients to the imaging centers, and they all wanted us to be their radiologists. And so, that kind of impeded our growth in the scheduling and concierge business early on. I think it's going to be a great opportunity for us again. At our core really is a radiology group. And what's happening in the industry right now is all the mergers and acquisitions. These imaging centers were at 50% capacity for 3 months in 2020. Still, everybody's at about 80% of typical capacity. Costs are dramatically higher and lots of reschedules and cancellations. And so a lot of the imaging centers have their Reyes and Simon Med and Acumen have been acquiring centers, and there are other companies as well. And then also in the radiologist space, they're emerging radiology. They call themselves super groups. In North Carolina, there's one that's 1,400 radiologists.
Wow.
And what they do is they aggregate the quote unquote good old contracts. They look at, 40 radiology groups contracts, and they find the best one and they start billing under that contract as a large group. And that's really driving up the cost of imaging. So what we saw in a recent set of Blue Cross Blue Shield claims data was that the percentage of the total imaging spend that was professional fees prior to the pandemic was about 22%. And in this last set of Blue Cross Blue Shield data, it was 45%. And the facility fee isn't going down. So that's just being added to, to the top line.
You make a point that one important component of getting this underway is educating employers. Why is that, and what does it mean?
The perception is that people want a Blue Cross Blue Shield or Cigna or Aetna card in their pocket. What they don't realize, and this is there's a great case study about this. There is a school district in Central Florida, School District Osceola County, where in 2019 the employee wage increase was completely wiped out by the increase in their Cigna premium. Not only that, these employees had a $4,000 deductible and then a 50% coinsurance up to a $6,000 maximum out of pocket. So basically, they were paying 20% of their income for a health plan they couldn't afford to use. And so the teachers union went to the school board and said something's got to give. And so they looked at what was going on. And actually, the near site clinic was in a hospital system where we know the cost of care is 5 times greater typically than that with an independent physician.
At least.
And so the district implemented, they still had Cigna in place. They couldn't do anything about that for another year, but they moved the near site clinic to the Rosen Health Center. And that's a great story in and of itself. And they put green and at zero out of pocket so that the employees had access to this, not just a clinic, it's a true health center. And then they also put green imaging in at zero out of pocket to assure that they could get the imaging exams they needed. And we saved in the first year, we had estimated 1.3 million in savings. We actually saved the district and its employees 1.5 million in 2020 despite the pandemic, and it's 2.5 million this year. So what employers have this idea that people want a Blue Cross Blue Shield card. What they want is affordable, high quality care.
Right.
And there's so many ways to achieve that, even with a Blue Cross Blue Shield card in the pocket. I have a friend who owns urgent cares here, and these nurses want what we call a BUCA, Blue Cross Blue Shield United Cigna Aetna card. But she pulls everything she can, and we did this at Diagnostic Clinic as well. We pulled everything she can out with direct contracts so that they never touch that Blue Cross Blue Shield plan and her premiums stay low. And so her employees come to Green Imaging.
Are you astounded, as I am, that in spite of the fact that Blue Cross Blue Shield is really not doing anybody any favors for the most part, they are looked upon as the gold standard still?
It really is. And, somebody, I think it's Keith Smith that put it really well, when every doctor is I'm not, but almost every doctor we know is in network with Blue Cross Blue Shield. What's special about that? What are their quality measures? What are they doing? What kind of fiduciary duty are they providing? So it's really pretty fascinating.
They certainly have complete lock on the system in the state of Alabama where I live. And you're absolutely right. Nobody seems to be asking the right questions, but we're getting closer because of people like you, and that gives me some room for enthusiasm. You're really getting way beyond radiology and into the nuts and bolts of where the money comes from. And again, I find this to be remarkably unusual for a radiologist. But in the blogs and pieces that you've written, one of the things that impressed me is you have a 3 simple solution expose, and number one in that list is primary care as the foundation. You want to talk about that a little bit?
I really do. 90% of care in this country can be performed by a good primary care physician. And it's really fascinating that we have people who hurt their knee and the first thing they do is go to an orthopedist. Mm-hmm. And the great opportunity for primary care is that right now it's on an unsustainable model with the fee-for-service model. A doctor to make a living to pay off their student loans, has to see 20-something patients in a day. And that does not, and they spend over 50% of their time recording that information in an EMR and an electronic medical record. So it doesn't make sense. But if we can capture more at the primary care level and pay the primary care doctor fairly, we achieve tremendous savings. And, one of the things that we love at Green Imaging is that we're easier to use than the traditional system. And that's what everybody says about direct primary care or the subscription-based primary care, is that healthcare becomes so much easier. Not only is this primary care doctor taking great care of them, of their kids, frequently if there's a specialist referral that's needed and it's a telehealth, that direct primary care doctor is on the conference call with the patient and the specialist, and not relying on a consult they receive a month later, but really discussing the patient in the way we used to over lunch.
Exactly.
And so the other thing that they do is they serve as a Sherpa through the health system, so that redundant testing isn't performed. If somebody really does need to go to the emergency room to rule out appendicitis, the DPC doctor can share with the ER doctor, what the labs were today, what the ultrasound showed, what, the clinical information leading up to the ER visit, and avoid redundant testing. And also, provide frequently a much more insightful history than the patient might be able to relate when the patient's in pain or ill.
Absolutely. And then the second component of that, of your 3 simple solutions, and this is the part that just absolutely astounds me the most, and that's the price transparency or lack thereof. Where did that come from?
There was an interesting article that came out in the radiology business journals today about why price transparency is failing. And, one of them is the specialists that do split billing. And so about 70% of imaging in this country is split billed, where the facility bills for the scan itself and the radiologist bill the professional fee. And interestingly, a lot of the specialists don't want to play along and, provide flat fees for the hospital so that the hospital could provide a bundled charge. Not that the hospitals want to play along with transparency, but it's one of the reasons being cited. The other thing that I think is so hard for hospital transparency is actually, part of the problem is not just the cost of the study. Part of the problem is the redundancy of care, where a patient might have a, CT scan as an outpatient, and then 2 days later it's the same exam with no change in symptoms is repeated in the hospital because they don't have the record of the prior. So many things are wasted, and those just add to the cost. So even if you can look up that I'm going to have a cholecystectomy, I'm going to have my gallbladder out, and this is how much it's going to cost. If you, had an anesthesia reaction and this, you're not going to be able to predict many of the expenses that happen down the line. And so, that is one of the things when we get to bundled pricing where actually, the risk is being written into that bundled price. That is a solution. But right now, the hospitals and the insurance companies have no incentive to release these rates that they've negotiated. They're making record profits, and they can, whatever the penalty is, it's a slap on the wrist right now for not complying with the transparency. And even the ones who comply do it in very interesting ways. They will only release price. A lot of them you have to submit an inquiry, and they will only submit pricing to the patient, him or herself, not to a third party. So a DPC doctor can't go shop on behalf of the patient. There are a lot of interesting strategies that they're taking there, where in fact, I think, there are a few. I know that the Cristin system here in Houston, we've been able to, my husband went in and we were on a defined benefit healthcare plan. And so the first surgery, he had kidney stones and ended up with one procedure right before Christmas and the other, of course, January 2nd with no deductible. The first one, he was billed out at 30,000, and we were able to negotiate it down to 10,000. And the second one, we went in and it was planned, went in and negotiated a cash rate, got it for 5,000, and it was billed out at 40,000. So, some of them are starting to work with patients, and I think that we will start seeing more and more of that. The health sharing ministries are really catching on, especially Sedera. That is, encourages patients to go out and be basically self-pay patients, and then they get reimbursed by the health plan. And so I think we're going to see more and more negotiation like that. We're going to not see the hospitals themselves being transparent for quite a while.
If you can, give us a simple explanation for why lack of transparency is so terribly important to the hospitals.
Because it's protecting their way of life. The hospitals, last I saw, I think it's 8 administrators per doctor in a hospital system. They're very heavily, and there are lots of regulations they have to comply with. I will say that. They are highly regulated. There's lots they have to do. And they have to stay safe, and they do complex things, and they do a myriad of exams. I understand that piece of it. But still, the administrative burden is very, very expensive. And they get paid a lot more than doctors do, is the other
They
kind
really
of
do.
dirty secret in there.
Yeah. I practiced for 44 years, and in that period of time, the number of administrative personnel increased by 3,200%. I still can't understand what the justification for that is, and then I think you just gave it to me. It's just part of the subterfuge.
Right.
And that sort of leads me into my next question, one of the things that you've written about a lot in your blogs, and that's the middlemen. You want to give us a little expose on just exactly who the middlemen are and who they represent and why they are truly, I think, the worst of the bad guys.
Yeah, I mean, they occur all throughout healthcare. And I always want to throw in unnecessary middlemen, because there's some middlemen who are serving a great purpose. And I would say that's, medical management is kind of a dirty word in imaging, because they've thrown auths at us, and auths do nothing to change utilization. They just slow down the process and add more friction to the imaging process. But medical management done properly can redirect patients to higher quality, lower cost sites. And AIM, Deb Alt, who's a nurse, founded AIM, and she does just that. She gets patients to top 5, their rankings of surgeons, and she tries to get them to the top 5 or 10%, in for that surgery that's performed. And it's amazing how when you show patients, that here's your doctor at 43%, here's this doctor in the same practice that's at, 92%, how easy it is to redirect. So, there are people doing good middleman work. There are also people who are doing, PBMs up the cost of, and the pharmacy benefit solutions. Is that what benefit
Pharmacy
management?
Benefit managers, yeah.
Those are middlemen who nobody, are just shoveling around air. Trading air, I think. And they're just, they're serving no good purpose except to drive up cost. That would be an example of that. I think another really is that we don't talk about much, but not-for-profit hospital systems. My dressing room looks out over the Texas Medical Center, and I look out there and I look at all those quote-unquote not-for-profit hospitals sitting there on the most expensive real estate in Houston, using our resources, our trains and buses and roads and bridges, and and not giving back to the community. Since the Affordable Care Act came into existence, the percentage of charity care that hospitals, quote unquote, give away has dropped from like 7 to 13% to now it's about 3%. So they're actually doing even less for us. And, in Houston, at least, they've become REITs, real estate investment funds, basically, because they're buying up all this suburban land, building these big buildings that are half empty. These doctors go out there, one day a week to see patients in the suburbs. And really they're, enriching their portfolio with this expensive land. And, that's one of the ones that I find the most bothersome. And yet they get so many advantages as compared to for-profits, and how they get to operate.
Yeah, they really do. And that's been a great puzzlement to me, because one of the, as you've already mentioned, one of the justifications for giving them the tax breaks is that they're supposed to, that's supposed to offset their disadvantage. And when you look at them, it's very difficult to see exactly where their disadvantages actually are, because they look like they're doing very well. You want to talk a little bit about what it is about the terribly flawed system that we have that makes predatory pricing so easy, so possible?
It's the complexity of the way coding and billing are performed. And so it is very important to have some standardized way to describe what occurs in a medical encounter. For example, a chest x-ray. It is very logical that we have a code for 2 views of the chest as compared to a code for 4 views of the chest. The time in the room, the radiologist's time, all of those things have to be factored into what's paid. And so the AMA actually owns the rights to the CPT codes, which are the ones that we use to code what happened in the medical encounter, and the ICD-10, which are how we code what the patient's symptoms and findings are. And those are used ubiquitously throughout the system. Well, there is a lot of lack of, maybe intentional complexity. For example, there is a code for bilateral hip x-rays, but there's not a code for bilateral elbow x-rays or bilateral shoulder x-rays. There is no logic to the way this is put together, which makes the complexity for everybody who's doing labor in this market to everybody has to look things up all the time and figure things out and ask questions, thus adding to the cost of labor. But the other thing is it makes it really hard for somebody to really understand what's going on in the claims data. So in Texas, we have a law where employers over a certain size have, I can't imagine that employers of a smaller size wouldn't have access to their claims data. They don't. But if you're a big enough employer, you can have access to your claims data. When the BUCA plans send these across to the whoever it is, the employer himself, the benefits advisor, somebody who's doing analytics for them, they send it over in a mush. It's nonsensical. It's frequently missing some of the modifiers, some of the fields that you need to analyze it. But when you are persistent and you get a large volume of claims data, it's still complex to know what's going on in that system. And I will tell you that I actually had a TPA, a third-party administrator who processes claims for a health plan, send out a comparison, a quote-unquote comparison of Aetna pricing compared to Green Imaging's. And what they did, they showed that we were about the same as Aetna, which is not true. And what they did was they just took the CPT code and they averaged it by the number of exams that were performed, instead of what you have to do with imaging, because 70% of those exams are split billed. You have to look at the modifier and you have to break out the professional fees and the technical fees, add them together, and then divide them by the number of exams performed. So if the analytics are not done properly, you get false information. And even people who are supposed to be experts in this, like a TPA, doesn't always understand the complexity of what they're doing. So it's really, I think it's intentionally broken, which just continues to make all those administrators necessary.
Yeah, I hate to even think that a system was created specifically for the purpose of making it difficult for people to understand it so that you could take advantage of them. Maybe it wasn't purposeful, but it certainly has worked out that way.
I would agree with you. I have a hard time thinking people were scheming in the back room, but it has certainly served to their benefit.
Yeah. If you are a non-medical person, but you're a consumer of healthcare, which, everybody is, there is a tendency to think that it's the insurance companies that are absolutely to blame for everything because they charge these enormous premiums. And when you go to get care, you find out that sometimes more than half of what happened to you isn't covered. And so it's easy to think that the insurance companies are truly the bad guy, and I suspect that there is a significant amount of badness to them. But are they the real issue? Are they the real problem?
No, I think it's pervasive throughout the system, but I think a lot of it is just the complexity. And Marshall Allen, who's was a ProPublica writer and is now with Health and Human Services, interestingly, published a book this year called Never Pay the First Bill. And I always joke with him and say it should never pay the first bill unless it's Green Imaging bill. But we are in the book. But he gives strategies for how to become a better consumer. And I think it's really tough for people to become a good consumer. But what he does is he explains why and how things are broken and how you can combat that. And I think the more we do this as individuals, we take back our own healthcare, whether it's a BUCA plan on the exchange, whether it's a health sharing ministry. Actually, my husband and I have been guinea pigs. We've tried all kinds of healthcare plans, and we're now on Sedera, which is a health sharing plan. And we find it to be truly wonderful. It's very freeing to really not have to worry about any of the bureaucracy of healthcare. We go in as self-pay people, and if we're to meet a certain threshold, we're going to have that expense shared with the whole group. But it's really it's refreshing. And but Marshall really gives you the kind of strategies you need to take back healthcare, how to find good care,
Mm-hmm.
how to find care that's, even if you're somebody who really doesn't qualify, you really needs the high risk pool of an Affordable Care Act plan. That doesn't mean that you need to be ball and chain getting healthcare from that plan.
Yeah, the hard part for insurance for me is there are so many surprises in what you thought was covered that isn't covered.
Right.
And then the other thing is the way things get priced. How are you supposed to know the kind of insurance that you need? It's bound to be agonizing for most consumers. It certainly is for me.
And certainly, that's where subscription-based primary care, even if you are paying for a traditional healthcare plan, that's where subscription-based primary care can really save you money. Get you good RX. That some of the DPCs can self-prescribe. Can do actually fill prescriptions. In some states, they will get you to afford. If you're not going to reach your deductible, they will get you to affordable self-pay specialists and labs, and everything you need can usually happen under your deductible if you're on a high deductible healthcare plan.
Well, Dr. Cristin Dickerson, this has been a very enlightening conversation, and I appreciate more than you know your willingness to sit down and share your time with us. We are at the point that I enjoy the most in my program, and that's when I just get out of the way and let you speak to us from your heart. So I'm going to close my mic, and Dr. Cristin Dickerson will give us her personal prescriptions for success.
Okay. My prescription is number one, to stay flexible and be ready to pivot. My career has taken, as you heard today, me down many paths. I still am ready to pivot if something changes healthcare in this country, whether it would be universal coverage, whatever it is. I'm already thinking of ways that I could pivot and be flexible and absorb that. So I think although we all do need to create our future in our mind and know where we want to head, I think if you are too married to that, you stand the chance of missing out on some really great opportunities. And so number one would be just be flexible. And number two is persistence. And, there have been several times in my career where, and we didn't really touch on this one, but I actually lost my partner in green imaging. A 42-year-old radiologist didn't wake up one Saturday morning. And so there have been times on this 10-year path with green imaging that, the pandemic really, we were at 50% capacity for 3 months. I, had 20 employees. There have been times when I wasn't sure, that this was going to happen and make it. And I think persistence. I think waking up the next day and saying, okay, what can I do to make this better? And, how am I going to keep this going so that we can take care of more patients more affordably, has really been that answer. So just stick with it. Whatever, if you believe in something, stick with it. You can find creative ways to make things work, and you'll find people along the way who help you do that. So those are really that's my RX for success.
Well, there certainly is a lot of wisdom there, and we are indebted to you for spending some time with us and sharing that. Before we go, I want to give you an opportunity to advertise a little bit. So if you'd like to tell our audience where they can find you and what you represent, we're ready to hear it.
Absolutely. Actually, my email address is drdickerson@greenimaging.net, DRDICKERSON @greenimaging.net. Happy to help you, launch on your path to becoming a better healthcare consumer or a physician who, wants to take a different path and start looking at direct contracting. Those are all things that I really love mentoring. And our website is www.greenimaging.net. If you ever have an imaging order, you can actually just take a snapshot of it, of your order, and text it to, and it's a secure messaging system. Text it to 713-524-9190, and that will start the referral process. And you'll either, whichever you prefer, receive a text back or a phone call back, and we'll get you scheduled. So thank you so much for having me, Randy.
Well, Dr. Cristin Dickerson, thank you so much for being here. It's been a great pleasure, and maybe we'll have you back again sometime.
Thanks so much.
Thank you so much for listening with us today. Remember, you can get more information about our guests as well as hear them face my rapid-fire questions at our Patreon site. And while you're there, you can also subscribe to the podcast, give us a rating, and hopefully offer suggestions on what you'd like to hear in future episodes. Thanks very much to Ryan Jones, who composed and performs our theme music. That's all we have for now, so please be sure to fill your prescription for success with my next episode.